This
Everyone,
conference will now be recorded.
good evening, everyone. This is Charles Brummel. I'm the Chief Executive Officer for Lupus Society of Illinois, and I wanted to welcome you to our webinar this evening, COVID-19 and Lupus community. And this will be discussed by Dr. Robert Katz. I have a disclaimer that I need to read, so let me just do that first. This event is for educational and informational purposes only and serves to benefit our mission. The Lupus Society of Illinois does not provide medical advice or recommendations. This information should not substitute or replace expert medical care. Before making changes to your medical care, consult your qualified healthcare professionals familiar with your medical condition and health status. This event is being recorded and will be archived on the Lupus Society of Illinois website. So now I'd like to introduce our speaker this evening, Dr. Robert Katz. Dr. Katz is an associate professor of medicine at Rush University Medical Center, a graduate of Columbia University and the University of Maryland Medical School. Dr. Katz completed his internal medicine training at Washington University Medical Center and his fellowship training in rheumatology at the Johns Hopkins Medical School. Dr. Katz became a master of the American College of Rheumatology at his meeting in October 2014. Just pay attention to that. There's not very many doctors who are viewed as masters in their profession, but Dr. Katz is one of them. Currently, Dr. Katz serves in differing capacities on various boards, including chairman of the Medical Advisory Board of the Lupus Society of Illinois and the board of the Arthritis Foundation of Illinois. Nationally, Dr. Katz serves on the board of the Lupus Research Alliance. Dr. Katz has been a recipient of multiple awards and has been included in Best Doctors in Chicago, the Best Doctors in Chicago issue for every 2 years from 1998 through 2020. Guide to Top Doctors, every edition from 1999 until 2020. Castle Connolly Guide to Find the Best Doctors, each edition from 1999 to 2020. So without further ado, I'd like to step aside and let Dr. Katz begin his remarks. Dr. Katz?
Thank you, Charles. Thank you. I love being a member of the Lupus Society. You know, when I first came to Chicago, and that was a few years ago, I joined the Lupus Society. At that time, it was called the Lupus Foundation, and I've been involved ever since. Lupus is a passion for me. I love lupus. It's a fascinating disease. When I was at Johns Hopkins, I studied it, and I grew very attached to lupus. It's sort of an enigma in many ways because there are all these different antibodies floating around. It's a greater understanding of autoimmunity, immunity against self, not just protective immunity. And I've seen great advances in the field of immunology and rheumatology and lupus over many years, so that we've got it under control in most cases, actually. And then all of a sudden, we made the news again because of hydroxychloroquine and Plaquenil. That's a sleepy drug for a lot of people because it's only in our field that we use it. I mean, it's hardly ever used as an anti-malarial these days, even though that's how it was developed, until this COVID-19 came along. And all of a sudden, somebody, I wonder if you can guess who it was, suggested that this might be an effective therapy for both prevention and treatment, making the illness of coronavirus, which is a horrible illness. On the other hand, maybe it's getting contained, this pandemic, but trying to control it with whatever means we have. And Plaquenil came up. So that's what we're going to discuss today. We're going to discuss COVID-19 and lupus and the relationship in terms of Plaquenil, and are you more susceptible because you have an autoimmune disease? I hope you can see all these slides. I guess they're up now, the first one.
Yes,
So let's go. All right, let's start with a discussion of COVID-19. So COVID-19 stands for coronavirus, corona, C-O, virus, which will show, and V is for virus, VI is for virus, and D is for disease. COVID, and it's 2019. The first cluster was discovered in Wuhan, China, and it was designated also the severe acute respiratory syndrome coronavirus, SARS-2. SARS-1 happened a number of years ago. That was also a pandemic, but this one is worse. Let's see here. So this is what our famous coronavirus looks like. And it's got all these little kind of crazy proteins. I mean, you can see the crown on the crown on this RNA, ribonucleoprotein virus. So you can see internally there's that RNA and inside, and that's kind of what is the thing that makes it contagious, to communicate that RNA to other cells. It's got spikes, S. It's got the membrane M, it's got the envelope E, and that's kind of what it looks like. It's kind of interesting. It looks like sort of a Lego thing. I don't know. What do you think?
Yeah.
And so here again, the spike surface glycoprotein, the M protein, the E protein, the nucleocapsid N protein, which contains the RNA. And that's kind of important, because if you're going to make a vaccine, you want to make this against certain proteins. Like, do you make it against the envelope protein or the membrane protein or several proteins of this COVID-19 virus? And again, it's covered with spikes, protein and lipid. The virus is enveloped in a bubble of oily lipid molecules, which falls apart on contact with soap. And then you see there's a receptor in the cell. Do you see it says ACE2? Well, that coronavirus attaches to that receptor, and that's how it gets into the cell. It just, boom, attaches. See, like that? And it's in the respiratory tract, these receptors. And then it releases the viral RNA inside the coronavirus into the cell. And that way it propagates and makes more viral RNA. And then it releases many, many copies of the virus before the cell finally just breaks down and can't stand it anymore. And especially in the lungs, it hijacks the lungs and it hijacks the cells. And it's 30,000 genetic letters long, where ours genome is over 3 billion. So this infected cell reads that ribonucleoprotein, RNA, and begins making its own proteins that will keep the immune system at bay and make new copies of the virus. Let's keep going here. They're chaotic, out of control. And as it makes these viral proteins, and you can see them, it's reassembling this coronavirus, so there are many more copies. And there are new copies that are being made all the time and propagating like crazy. And it's up to our immune system to contain this RNA virus, and usually it does, but not always. So there's an immune response. Sometimes the immune response is actually too vigorous. And as the immune response, it becomes that way, sometimes we have to damp it down with some biologics like interleukin-6 antagonists and other things, because the immune response can lead to death if it's a storm, if it's too crazy, and that can happen in the immune response. So two recent outbreaks of viral were caused by the coronaviruses. One was the severe acute respiratory syndrome and the Middle East respiratory syndrome. These are similar to two bat coronaviruses, and it appears that bats might be the primary source of this coronavirus, which is now spread to humans. The virus has a very long lag time. The patients who get it are asymptomatic, and that's the problem partly with this virus. They're asymptomatic for many days before developing a cough and fever. So the illness is difficult to treat, in part because people are very infectious, but they don't know it. They're not symptomatic yet. So they're community carriers, and that's a problem. And the clinical manifestations are patients in Wuhan were fever in 99% over 100 degrees, fatigue, a dry cough, not a productive cough that you get from other kinds of pneumonia usually, loss of appetite called anorexia, myalgias or muscle pain, shortness of breath in 31%. And those are the ones you really worry about, the shortness of breath ones. And here are some risk factors. If you're over 65, if you have underlying lung disease, if you have underlying kidney disease, diabetes, high blood pressure, history of cardiovascular disease, obesity, biologics we're going to get to at the end, but they don't appear to be a risk factor so far in terms of studies that are being done now. There doesn't appear to be a risk factor that makes you more susceptible if you're on illnesses that are immune suppressants for, to help you with lupus. These are some of the risk factors. So data on COVID-19 in patients with immune-mediated inflammatory disease who have received we call them biologics or anti-cytokine biologics, or methotrexate or Imuran or other immunomodulatory therapies. There's not a lot of data, but a new study out of New York shows these findings suggest that the baseline level use of biologics is not, can I say the word not twice, associated with worse COVID-19 outcomes. So if you happen to be on Imuran, if you happen to be on, Benlysta or things like that, they're not seeing any sort of worsening of the COVID outcomes, which is good for our population. So once infected, people start developing severe shortness of breath. If that happens, then they're getting pulmonary involvement, and this is a trigger for getting them to the hospital. When they come to the emergency room, if they're not having low oxygen levels, so they check your oxygen level, a lot of times just on the finger and stuff, what's your oxygenation? If it's not low, they're sent home to quarantine and rehabilitate. But if they are having low oxygen levels, starting to get lung involvement, they're admitted. Then a proportion of those patients, like 20 to 30%, become so loss of oxygen, so hypoxic, that they need to be admitted to the intensive care unit and put on a ventilator. The problem is it's so difficult, this disease, these patients can have a protracted course of ventilation. So once it involves the lung, man, you are in the ICU, you might be on a ventilator, and that's trouble. If somebody walks in there, they see huge fans that filter viral particles from the air. There are hundreds of overlapping beeping sounds from the monitors, ventilators, and pumps. These are heroes that are people that are working in these intensive care units taking care of COVID-19 patients with lung involvement. It's an insidious disease. Young people survive easily. They have a high fever, 2 to 3 day illness, they're better. Elderly patients, they have a difficult time. In the early phase, some have been empirically treated with hydroxychloroquine, azithromycin, and even zinc. And that combination, according to this person who wrote this little article, we're going to discuss the controversy about the effectiveness of hydroxychloroquine here. This person thinks it's been very effective. I am leaning toward the side of being a believer or an early adopter, but I absolutely agree that randomized trials are going to be required. And as you know, in science, for something to be approved, it has to be in a controlled trial, usually compared to a placebo, where the people getting the drug in the trial don't know if they're getting the real drug or the placebo. And even the people caring for these patients don't really know. At the end, they unblind it, they find out what you were taking. Were you taking the real drug? Were you taking the placebo? And see what the outcome differences are. So until they're randomized, controlled studies, placebo-controlled, and peer-reviewed by other people, not just the people doing the study, no one is going to be able to agree on this effectiveness of hydroxychloroquine and azithromycin. Nobody, but some people have a good feeling, not everybody. So in China, 187 patients with lupus who were taking chronic hydroxychloroquine or chloroquine did not get COVID-19. If you look at the rheumatology literature and lupus literature, hydroxychloroquine is very safe. I've been using it for decades and I hardly ever see problems. I used to see eye toxicity for people using it for many decades, occasionally, not even that. In the instructions for use, there's no consideration for a cardiac problem, including this QT prolongation. I've never seen that. Now, if you take really sick patients with myocardial or heart involvement here, yes, you're going to see QT prolongation, which they could blame on the hydroxychloroquine. But I think it's a very safe drug. Whether to use it, I'm going to back away from that. But I have not seen a cardiac toxicity from it. And I think it's only patients who are really sick who are going to get that, and more from the illness than the drug. There are not good randomized trials, but this group in Marseille, France, treated 900 patients with a combination of zinc, azithromycin, and hydroxychloroquine. I'm not endorsing it, I'm just reporting it here, with a 0.4% mortality. And then they published the results. It was not a randomized placebo-controlled trial. It wasn't like some people were getting placebo and they didn't know if they were getting hydroxychloroquine or the placebo. They knew. If they treat patients within 1 week of symptoms, they only have a 1% need of requiring intensive care unit admission. It's a very well done registry, but it's not definitive and whether or not this combination works. A study in Brazil showed that high doses of not hydroxychloroquine, not our Plaquenil, but of chloroquine resulted in some arrhythmias. But again, I'm not even sure about those patients were so sick, had heart myocardial involvement, but that's not hydroxychloroquine, which I think is quite safe. Whether it's effective is more the issue to me. And then in this China study, the infection has started 2.3 days prior to symptom onset, which is the problem. People are walking around with their secretions and they are infected and they don't know it and you don't know it. And then it peaked 0.7 days before symptom onset and declined within 7 days. So the infectiousness is even worse when you're asymptomatic, and then when symptoms start, and then it declines over the next week. So patients may be infected in the earlier stages, they may be more infectious. Antibodies to the virus are induced in those who have become infected. I had my antibodies tested the other day. They just came out with this test. I got it through LabCorp, and I was IgG negative. I wondered whether I had a cough, in January, whether it was early coronavirus, but it wasn't. So you can start getting these antibodies now. The immunoglobulin G antibodies, IgG antibodies, show that you've had an infection before, whether it's IgG antibodies to measles or coronavirus 19 or whatever it is. But now they're getting these antibodies out to see who has been exposed. That doesn't mean you have it. It means you had it. There's an IgM, immunoglobulin M antibody, that's more associated with active coronavirus disease. But nobody knows exactly how accurate these antibody tests are, but they don't need a nasal swab to do them. It's a blood test. And, the nasal swab just shows if you have it now. The immune response test shows whether you did have it. And we don't know how long that protective effect will last if you have the antibodies. In terms of the spread, respiratory droplets, typically droplets don't travel more than about 6 feet. So that's the 6 feet spacing. And they don't tend to linger in the air generally, although there's some controversy about that. And the RNA from the COVID-19 virus has been detected in blood and stool samples as well. What did our friend Donald Trump say? He said, hydroxychloroquine and azithromycin taken together have a real chance to be one of the biggest game changers in the history of medicine. The FDA has moved mountains. Thank you. Be put in use immediately. People are dying. Move fast. God bless everyone. Who the hell knows? The only thing this did was bring lupus and their drug hydroxychloroquine into public scrutiny. Who knows whether it's going to be valuable or not. This is how Plaquenil was developed. It started back in a long time ago, 1630, finally developed. It was approved by the FDA for medical use in 1955, and we started using it for lupus over time, and now many, maybe even most lupus patients take hydroxychloroquine. And dosing strategies and that sort of thing are still being worked on. So it's a cornerstone of medical management in many ways of lupus. It's been shown to prevent flares, decrease blood clots, improve lipids. It can treat the skin manifestations, the arthritis, and it's been shown to enhance the response to other treatments in those with kidney disease, and is associated with improved survival, and decreased organ damage. So pretty good there, and not a steroid, which is very effective, but many more side effects, as you know, with steroids. Up to 44% of our lupus patients, however, did not take the medications as prescribed. This is similar as reported in the literature in lupus and other chronic diseases. Pharmacy refills have shown that many patients, 51%, are not adherent to their hydroxychloroquine. And it wasn't due to income or education. They just don't take it sometimes. Is that because of it's too much trouble or getting refills or, whatever it is? But non-adherence to medication, lupus, is associated with poor outcomes. Really, you gotta follow up, even if you're doing fine. And more outpatient visits, emergency room use in those who did not adhere to taking their medications regularly. And that also affected kidney impairment and chronic renal disease. So take your medicine or discuss it with your doctor whether you should change your medicine, but non-adherence is a factor. Now you can measure blood levels of hydroxychloroquine. This is rather new, and we can do that now. And we want to keep it within a certain range on the blood level, especially if there's a question of the efficacy of the drug. But chloroquine is also, as hydroxychloroquine has, been reported as a broad-spectrum antiviral drug too. And research has found that chloroquine effectively suppresses the COVID-2, and is found to be, and hydroxychloroquine or Plaquenil is more potent than chloroquine in SARS-CoV-2 in vitro cells. So that, all of a sudden, it looks like our drug, our lupus drug, has some antiviral efficacy. And then, those with an underlying prolonged QT interval, but again, I've not seen that really. But if you have a cardiac involvement, okay, that may be different in terms of staying away from hydroxychloroquine, but I haven't seen problems with it. And but you can get a retinopathy. You can get a change in the macula, in the most accurate part of the eye in terms of vision, that causes a pigment to accumulate there, and that can lead to permanent visual loss. So you want to use a maximum daily dose of 5 milligrams per kilogram. They're 2.2 pounds per kilogram, so you can calculate 5 milligrams per kilogram. And so they've reduced some of the hydroxychloroquine doses in some people from the typical dose of 400 milligrams a day to 200 milligram tablets. Some people are taking 300 milligrams or whatever to stay within that 5 milligram per kilogram recommended dose. So again, based on 5 milligrams per kilogram is the ophthalmology recommendation. So because of the lack of robust clinical evidence to date, we don't have well-controlled, placebo-controlled studies. Considering the questionable efficacy as an antiviral drug for COVID-2, considering possible safety concerns, which some cardiologists have raised, although I think that really it's a safe drug, the danger of deprivation of these essential drugs to legitimate patients. I know you lupus patients have experienced that. We found generally that patients who have been prescribed it in the past can get the refills okay in general. There might be some exceptions, and those who've never gotten it before will have a hard time getting it for the first time due to panic stocking, instilling a false sense of protection among the mass of people. So the prophylactic use of hydroxychloroquine and chloroquine need to be further reviewed as data pour in. The data are not there. You could take it as a protection against, prophylactically of getting the virus, or if you have mild symptoms that may be the virus. Frankly, I might consider doing that too if I had the symptoms, but nobody knows how effective it is, and it has led to panic stocking of the medicine inappropriately. Okay, so again, there's improved survival, decreased organ damage. I went over that before. A Stanford School of Medicine study looked at 3,300 blood samples from volunteers and tested them for antibodies to COVID-19. They found that the infection fatality rate was 0.1%, 1 out of 1,000, or 2 out of 1,000. So, I mean, it's really, for most people, it's a very inconvenient virus. And for 1 out of 1,000, 2 out, according to Stanford, some will say it's much higher. It leads to death, especially in vulnerable populations. And in University of Bonn, they looked at 15% of the population was actually infected when they looked at 1,000 people. And then their mortality rate was 0.37%, 5 times lower than that currently registered in Germany, elsewhere. So, I mean, initially, I think the concern was that the death rate was extremely high, but when they're looking at all these people who now are being tested and have the antibody, they realize that actually a lot of people are asymptomatic or have mild symptoms and they're gone, and the death rate is not that that's not significantly important. You don't want to end up in the ICU on a ventilator, but it's not as high as originally thought to be. In this hydroxychloroquine and azithromycin trial of COVID-19 in France, reported in this Journal of Antimicrobial Agents and ongoing at the hospital in Marseille, they found a difference between the green, people taking hydroxychloroquine and azithromycin, in terms of the percentage of people that had active COVID-19 versus people on hydroxychloroquine only, the blue in the middle, and the control group in this one study, not randomized controlled, but the control group that was, had a much higher rate of positivity of the virus. So in this study in Marseille, this got people going that there looked like a very significant protective value of hydroxychloroquine, and particularly hydroxychloroquine and azithromycin. And this again looks at hydroxychloroquine and azithromycin were significantly more efficient for virus elimination. Another study again showed those on hydroxychloroquine versus controls. This study also showed that hydroxychloroquine got rid of the active virus particles by day 6 much more rapidly than if you weren't taking it. Is that true? I'm not attesting to this truth. I'm just saying that's what got people going about this thing. So, at day 6, 100% of the patients treated with hydroxychloroquine and azithromycin were virologically cured, compared to 57.1% of patients treated with hydroxychloroquine only, and 12.5% in the control group. Now, this is not the definitive study, but when you look at this thing and say, oh, maybe it is efficacious, and our lupus patients, in many cases, are taking it anyway. And so this is just more on the hydroxychloroquine story. I think I'll skip this one. Another randomized trial in China. And this also looked like it, this is sort of similar to what we showed before. And adding azithromycin seemed to help too, a Z-Pack kind of thing. And another thing in the US Veterans Hospital. And this also was a meta-analysis where the administration of hydroxychloroquine did not, let me say the word not again, result in a higher negative conversion rate, but there was more alleviation of clinical symptoms than standard care alone in people hospitalized with COVID-19 without receiving antiviral therapy. So it seems to be promising in terms of less number of cases with X-ray progression and with a comparable safety profile to conventional treatment. We need more data to come to a definite conclusion. Now, Fauci the other day came back and said, oh my gosh, remdesivir, when it has VIR at the end, see that, remdesivir? VIR means it's an antiviral therapy, like for AIDS or something, an antiviral therapy. And it appeared to be effective. And Fauci said, this will be the standard of care, remdesivir. Now that's given intravenously, so you have to be someplace where you can get it IV. And that's for people who really get pretty sick. It's not just for anybody, although maybe it'll be used in milder cases. And they'll look at other investigational therapies, the antiviral therapies, in addition to remdesivir. So Fauci said, that's the answer. I don't know. Interesting. A study published today in The Lancet showed no statistically significant benefit from remdesivir in 237 adult patients in 10 hospitals in China. Pardon me one second. For severe infection, but a faster time to clinical improvement among people who took remdesivir, the antiviral. Nothing to do with Plaquenil, of course. I just like the slide because it's a kind of crazy slide. I was still trying to figure it out. But this is the coronavirus and SARS and, you know, and a lot of things that are happening inside people who get this thing. And so I just want to end the slide portion with saying that, you know, there's a coronavirus 1 and there's a COVID 2. And this is the one that is affecting us. People suggested that our drug, Plaquenil, might be effective, and we're taking it anyway for lupus, or we could be taking it for lupus. It might have a protective value in terms of making the virus go away faster, preventing transmission of the virus, or it might not. And I think that we're still waiting to hear about other well-controlled studies, and there are many controlled studies that are going on now using hydroxychloroquine. So in a way, we're able to say that we're on the frontier here. And, you know, we've been, people have said, well, people are stockpiling it. That's been an issue on the news. Hydroxychloroquine is being used as an immune therapy. So why would it help, you know, a virus, you know, if it affects the immune system? And we all know that it's generally pretty well tolerated for most of us, and it may well be protective, but it's certainly drawn a lot of attention to lupus. So with that, I'm going to stand back for a second and invite questions about lupus, COVID virus, or anything you want to talk about.
Well, thank you, Dr. Katz. We do have a number of questions that have been sent in advance. So why don't I review those at this time, and then we can go to the chat area to see if we have additional questions. One question that we received was on the stay-at-home order. And the question is, should we try to stay at home, and for how long? You know, if the stay-at-home order is lifted, should we continue to stay at home, and for how long?
You know, that's where you need public health experts advising you what to do, not just lupus experts. So from a lupus standpoint, it's like I tell people who are going to get pregnant, or I tell people, if your lupus is well controlled, you're in good shape to do whatever you want to do. Pretty much, it's got to be well controlled. But I don't want to go into the public health arena, because some people are going to get this virus when they go out and to the workplace, and they are going to get this virus. If you're young, you'll probably do fine with it. If you're older or sicker, you won't do fine with it. So it has to be on a case-by-case basis. And, you know, they've had the social distancing rules and wearing a mask and gloves. And I'm not part of that community. That's the public health community advising people what to do in general. But if your lupus is under good control in general, I think that you're like everybody else, even without lupus, unless you're on very strong medication, have underlying serious lupus disease, or just feel psychologically uncomfortable going back to the workplace.
Okay. We have a question from a current lupus patient who indicates that she takes hydroxychloroquine. Does that help prevent me from getting the COVID-19 virus?
You know, in 6 months, I'll tell you, I would err on the side myself, if you of considering, first of all, if you have lupus, you could just take it anyway for lupus. So I would err on the side of taking it at this point. I might retract that statement in 3 to 6 months if they are well-controlled, peer-reviewed, meaning others have looked at the study too, data which show that it's not quite very effective, or there are many more effective strategies. But for today, if you've got lupus, it's an opportunity to take something which some studies, like the one in France, have shown to be protective, but not all studies. And the data are very preliminary. And just because, you know, it's announced at a presidential conference certainly doesn't verify that it's effective. But listen, it's a lupus drug.
Okay. All right. Next question. For people who have lupus, should they be worried about offering their bodies up to test for vaccines coming out, or should they just go ahead and not do it?
Yeah, I mean, vaccines can be slightly dangerous if it's a live virus vaccine, like yellow fever vaccine or something, and people who have some immunosuppression. But I always tell my lupus patients, if it's a dead virus, like, for example, the herpes zoster shingles vaccine was originally a live vaccine, but now with Shingrix, it's no longer a live vaccine. You can take it. So I would be a little cautious with live vaccines if that's what they come out with. But I think that if, who knows how effective they're going to be, but if the vaccine isn't a live vaccine, I think you can go for it.
Okay. A lot of people are nervous about this this virus, and certainly we've had a large number of people who have not survived it. So this question is in that regard, and it is, if she gets the virus, will she die? What's the odds that she will not survive?
Yeah, well, according to the study in Stanford and Bonn, it's like 0.1, 0.2, 0.3%, like 3 out of 1,000 that will actually die. I don't really know if that's valid. Maybe there'll be other data to suggest the death rate is higher, but the chances that you die from it without significant vulnerability. Now, for me, I'm old, I would definitely be a different category. You have significant lupus with organ involvement, you're in a different category. But otherwise, I'm not passing it over is not important. It is important, but they keep reducing the death rate based on some studies from a much higher. Originally, the studies were horrible, and now it's a big problem. I don't want to make it seem less significant, but the chances that you'll die for it are not great unless you have a lot of underlying risk factors.
Okay. This question goes to whether a person should run the risk of getting pregnant during this environment, or should they wait?
Oh, wait, what do you want? What's your hurry? I mean, hopefully this, like a lot of viruses, when the season changes, they go away. They can come back, but they go away, whether it's the flu or, SARS-1 or things like that. So, I mean, I wouldn't be in any hurry to get pregnant during this thing, because if you got sick and you got the virus and you were pregnant and also had lupus, I mean, it's like adds something to the risk factors for your pregnancy, and we don't even know about the babies in these situations. So I'd wait.
Now this is a follow-up question to the one you just answered, but more focused on lupus as opposed to the COVID-19 virus.
Yeah.
And the question is, if you have lupus, are the safety measures of a lupus pregnancy better today? There's some discussion about that. And in this particular case, the person asking the question has an associate who feels that they may not survive the pregnancy
Because of their lupus.
Because of the lupus.
Listen, one of the most famous stories of my professional career was a patient I still see who has lupus and had pretty severe lupus, and was told she should never have children. And I said, well, I don't agree with that. Once we calm your lupus down and put it into a remission, or at least quiet it down significantly, I would change that, because I know you want to have kids. I would go for it. So she did that. We calmed her lupus down. She took my advice, which others didn't agree with, to go and get pregnant. And she had twins born on my birthday. And I'll never forget that. So I think if your lupus is under control, it's your personal decision. There are no guarantees here. But I think if the lupus is under control, and you have to individualize this, this is not a generic thing in terms of everybody. I think that you could get pregnant.
Okay.
Not everybody might agree with me, but I think you can get pregnant if your lupus is under control.
Okay. Obviously, because of the COVID virus, we've been in a shutdown mode. We have a question here from a person who runs a restaurant, and he's currently out of work because of he has a compromised immune system. He not only has lupus, but he also has leukemia. So he's been at home, but he's thinking about returning. He's wondering if it's safe to return to his business.
Well, Charles, you know, again, the mortality rate, the lung rate, people on ventilators are much higher in people who have underlying risk factors. Active lupus would be one, although it wasn't listed, but active lupus. Leukemia would be another. I don't know how active leukemia is. So, you know, sometimes you do things that are a bit dangerous because you really accept the consequences, whether it's going to war or it's, you know, going out and back to work. You know, in general, one would say if this was a test question, don't go back to work with leukemia and lupus. But on the other hand, sometimes you have to individualize it and take some danger in your life. You know, this hopefully will pass in terms of a pandemic, and then it would be safer to do this, but you have to individualize those decisions based on economic and health factors.
Another question is, you know, fevers sometime appear during a lupus flare. And fevers being one of the symptoms for the COVID virus, when do you start to worry? How do you know it's a lupus flare versus a potential COVID breakout?
You know, I mean, one study I'm trying to do right now, actually, or gearing up to do a little bit, is again looking more at lupus subsets. So I'm saying to people, when your lupus flares, what symptoms do you typically have? A lot of people have a rash or joint pain or fever or chest pain with pleurisy. You know, what symptoms do you have? And usually when your lupus flares, it will flare in a certain pattern that you're kind of familiar with. So it won't just be fever. And to me, fever is over 100. It's not 99.6. It's over 100. And so, you know, number one, analyze your current symptoms compared to, you know, what your previous flares have been like. And two, you know, if the fever is high, like 102, 103, and there are not a lot of active lupus symptoms that you've had before, you know, you watch out here. And if you start getting a cough, watch out, you know, loss of smell, loss of taste, you know, those are other symptoms. So either it goes in one direction, which is the lupus direction, more joint pain, more, you can get some achiness, by the way, with coronavirus, more joint pain, more rash, more, you know, pleurisy, Raynaud's phenomenon with blue fingers, you know, versus I have this high fever of 102, but no real specific lupus symptoms, and maybe my smell and taste are gone, and now I have a cough, that's coronavirus. But sometimes to make that separation, although it sounds easy, can be complicated, and you may need blood work and other factors.
I have a question from a person who is a nurse in an emergency department, and she takes hydrochloroquine for her lupus. She has two questions. Once available, at what point do you think it would be wise for her to have antibody testing?
Well, number one, you're a heroine. So even though you're at your home, sitting at your desk or whatever, why don't you stand up and we'll applaud? Secondly, you know, you're on hydroxychloroquine, which is, you know, interesting and maybe protective. And so, I mean, I think that's wise advice, even though we don't know for sure if it works. But, you know, it's, you know, you're using all the personal protective equipment that you can and being as careful as possible. I don't know of any trials of hydroxychloroquine in Chicago at the moment. They're all around the country, though, and you mentioned in your thing, I think Texas and New York, but there might be others. If you go to clinicaltrials.gov.gov, they'll list some of these clinical trials for lupus and hydroxychloroquine and coronavirus. I do think that antibody testing is interesting. I got my antibodies tested, as I mentioned earlier, on earlier this week, and they turned out to be negative. But you can get the immunoglobulin G antibodies and the immunoglobulin M antibodies. Are they 100% accurate? I doubt it, but they're a good way of knowing whether you've been exposed. The polymerase chain reaction test, the PCR test, which is a nasal swab, that tells you if you have the virus, and it's probably more accurate for having the virus. But having contact with the virus, because that PCR changes when the virus goes away, I would recommend getting antibodies, yes.
Okay.
Antibody.
All right. Another question. For those who are currently taking 200 milligrams of hydroxychloroquine 2 times a day, do you think that we have protection? Does that help?
Listen, between you and me, just us, I think you should take it. But a year from now, if I were on this thing again, I'd say, oh, the data were negative. It looked like it was promising, but I would take it now. What the hell else are you going to do? Besides social distancing, besides, mask, gloves, washing your hands 50,000 times a day. I mean, there isn't much else out there right now. Remdesivir, if you're sick, that's an intravenous treatment. So frankly, go for it. That's what I tell on the side. If Charles said, what do you think? I'd say, take it. I would take, but I mean, the data are preliminary, not confirmed.
There's a lot of things being tested today with the hopes that it could be helpful, but it also is very confusing. I guess we should just we have to take our chances, don't we?
Yeah, in all the years I've been doing medicine, I've never seen it on the front lines, the front page, every news story. I've never seen it like this. So usually everything is sort of methodical, and you do these studies and then you report the results, and people don't even listen unless they have that particular disease. Now it's like up to the minute. What have we discovered today? And I don't think we scientists are prepared for that, because we need to have time to look at well-controlled studies to see what's effective and what's not, from a vaccine to an antiviral to a preventive therapy like the hydroxychloroquine. So stay tuned. But I mean, to me, the everyday coverage is kind of interesting in some ways, but it's really probably overdone in other ways, in terms of there aren't going to be great discoveries day to day or even week to week. It's going to take some time. But what Bill Gates said, I don't know if anybody saw this 2015 interview. He said that we prepared ourselves for nuclear disasters, for cyber disasters. To a certain extent, we've never prepared ourselves for pandemics. And whether it could be biological warfare, which this is not this case, I'm not saying this case, or whether it could just be another pandemic that comes in another couple of years, the only good part about this is to get our lessons, to learn how to prepare ourselves with enough equipment, with antiviral therapies and with vaccines that might be effective the next time around. So dealing with pandemics is an important lesson here.
And just to let you know, we got a few questions in the chat.
Okay.
One of them. Yes, so one of them is, are there any statistics that show the percentage of COVID patients and or fatalities in people with lupus?
Yeah, no, I've never seen a lupus study, and these people take hydroxychloroquine. The studies I've seen, or the ones I reported up here, are 1,000 people in that either Stanford, University of Bonn, or the French group in Marseille looked at those things, but they don't look specifically at lupus patients. But the study I showed you before, where it actually just came out the other day in the New England Journal of Medicine, really is a letter to the editor, said that people with autoimmune diseases and inflammatory diseases look like they fare just about the same as everybody else. And if they happen to be taking strong, biologic therapies, that they did the same as everybody else. So that's all I can report back so far, but I've never seen a lupus COVID study yet. We should probably do a few, because a lot of our patients are on Plaquenil, and compare those taking the drug to those not. But you got to get a large enough population to really see a difference.
Another question that's in the chat, Dr. Katz, is can you speak to the protocol of screening people by taking their temperature when we now know that a person can be positive and have COVID-19 and be asymptomatic, have no temperature? So is it really a valid screening measure?
Yeah, I think it gives people a greater sense of security, especially in, you know, I don't know where they're doing it. Costco, I don't even know where they're doing it now. But certainly in medical centers, they're doing it at my medical centers, Russia and Northwestern. So, you know, I think it gives people, but maybe a false sense of security, like you say, Charles, that a lot of people who have the virus are asymptomatic for a period of time, usually several days, and they don't have a fever. So I think it's offers a bit of you know, a false sense of protection. But you know, I'm not against screening people and asking them about symptoms too. If you had fever, cough, and those kinds of things, not only checking their temperature. It gives you a chance to pause for a second before you walk into a big store or a big medical center to say, do you have any symptoms, COVID virus symptoms? And also we'll check your temperature. So, you know, not a bad idea, but you know, not perfect by any means.
Now, are there any statistics that show the percent of COVID patients where there's fatalities and they had lupus?
And I've never seen a study their fatalities and they had lupus. I haven't seen it. You know, yeah, I haven't seen it. Someday they might separate it out and somebody might be looking at that. I wouldn't be surprised, but I haven't seen anything specific to lupus.
Okay. You know, we need a vaccine for this. And every time I hear someone speak about vaccines, they say it takes a year to a year and a half. Is that actually optimistic? Can we expect it to be longer before a vaccine is found?
I personally guess, this is guess, right? I think it'll be shorter because I've never seen such intense pharmaceutical action to do research and come up with a vaccine as I have this time. Now, there's not a vaccine against AIDS. There was not a vaccine against SARS-1, the respiratory syndrome 1. So it may never happen at all, but there's intense activity in terms of trying to come up with a vaccine this time. So I think there might be something successful, and people say year and a half, but it might be 6 months, but who knows? I mean, that's just a guess. We could gamble about it and make our predictions, but nobody knows. But I think they're really intensively working in that direction these days.
Well, this is a scary time. People are trying to make decisions on their own as to whether they should go back out to society. Should they stay in or should they go back to work as different states gradually allow companies to go open their doors? Do you have any advice for folks in that regard?
Well, you know, then it comes down to your personal view of life, which is that, you know, I mean, I hate to see the world and the economic activity of the United States completely shut down. People losing their jobs, losing their businesses. It's tragic. Being confined to their rooms basically for weeks and weeks. I mean, that has to end at some point. So, I mean, you know, I mean, ideally, I guess we should all stay comfortable and safe and not go out. I certainly, if I went out and went to the office and got sick, you know, and died, my family would never forgive me. On the other hand, I mean, at some point you have to deal with reality, and reality includes getting back to the workplace at some point. But I don't have exact timeline for you, Charles.
Yeah, yeah.
So we got a question that has been
covered all the questions that have been sent to us through the chat and through other vehicles. But I do want to make sure that that people are clear that you just talked about hydroxychloroquine, but you're still saying you don't know if it's effective. I mean, nobody knows it at this point. Isn't that right?
Nobody knows. I think they've exaggerated the adverse problems with it in terms of side effects, because I've used it for years and haven't seen cardiac side effects. I think it's only people who get really sick where that's going to happen. But on the other hand, it's hope. And I never thought hydroxychloroquine was an antiviral in the old days. I mean, if somebody had the influenza or something, I wouldn't put them on Plaquenil for that. So I always, when this first came out, a little suspicious that really, I mean, it works against malaria and maybe it has some antiviral activity, but really? So I'm still uncertain that it works, but there is some preliminary data, especially from France, but also from China and other places, that it might work. And so I'm hopeful, but I don't really know. The data aren't solid enough yet.
Yeah. Well, for anyone who knows you, they know that you follow the science and you want the data before you are going to endorse something. So I think this falls right into that category.
Exactly right.
Yeah.
Dr. Katz, do you have time to answer one more question?
Well, let's see. Maybe I can make time. No, of course. Sure. Throw it my way.
Well, a lupus patient asked, what is the reason why the patients with COVID-19 that are on the ventilator in a coma?
Well, okay, so your blood oxygen level is at a certain point. When your blood oxygen level, because your lungs get filled up with pneumonia and coronavirus, your lungs are filled up. The x-ray looks terrible. There's lots of, we call them infiltrates, taking over your lungs. Your oxygen level is low. You can't breathe independently. You just can't breathe independently. You are short of breath and you have a terrible cough. And that's when you go on a ventilator in order to allow you to breathe better. So that when your oxygen level falls below a certain point, you need something to help you breathe. But prior to that, you don't want to be on a ventilator. And being on a ventilator indicates much more severe disease, and the mortality rate then becomes much, much higher. So you know, if you can avoid a ventilator, but if you're so short of breath that it's hard to breathe and your lungs are filled up with pneumonia, you may have to go on one, but that's a sad state of affairs.
We do have one more question.
Sure.
And the question has to do with Plaquenil, and it is, if you have lupus, hold on a minute, and you're not taking Plaquenil, should you consider taking it?
Yeah, I mean, you know, it gives you an excuse to take something before the data are out. No data, your guess, my guess, Charles's guess, anybody's guess. You don't have to be a scientist to guess, you know, but you have a reason to take it for your lupus. So maybe during the season, until they prove that it's completely ineffective, a waste of time, maybe you want to take it. I've had a number of my lupus patients ask about going back on it because they were off of it, or going on it. And I gently encourage them, but I explain there are really no solid data yet. But yeah, why not? Why don't you take it? Because it's being investigated and we don't yet have the answer.
Yeah. I mean, there is some concern about shortage of the hydroxychloroquine,
Right.
you know, because so many people have been looking at it as something that might be helpful, and that causes a problem for the people who have been using it for their lupus.
It does. So I think that if you actually have lupus, you should be entitled to it versus, you know, your friend's friend who read about this thing or saw Trump on TV or something. So, I mean, you know, I think, but if you have lupus, it makes sense anyway. So I'm talking about the people who actually have lupus. I would take Plaquenil at this point. Is it an extra protection? We really don't know. People who do not have lupus, I mean, I'm not saying don't take it, but I'm not recommending it if it's going to result in a shortage.
Well, Dr. Katz, I think we are ready to wrap up at 7 o'clock. I'm looking in the chat room, and in addition to the questions that we've covered, I have a number of people who have just messaged in to thank you for the care that you've been giving them and their loved ones. So we appreciate you taking the time to be with us this evening and answering these questions and talking about this very challenging topic.
Listen,
So
I'm so passionate about my patients who look to me to be knowledgeable and to take care of them. So I very much appreciate that feedback.
Good. If there are other questions that come in after we close, you can direct those to the Lupus Society office, and we will make sure that those questions get to Dr. Katz, and we'll get those answers for you in a short while. All right. Well,
thank you for hosting this.
Beg pardon?
Thank you for putting this on, hosting it and organizing it.
Sure. It's our pleasure. And thank you for being here. This was very important. A lot of mystery, a lot of questions about what's going on. But you gave us a lot of clarity. So we're really appreciative.
My pleasure. Thank you for asking.
Okay. All right, then I'm now going to close. I thank everybody for being on the line and for your questions and your participation. So we're going to close the meeting now.